and today my task will be, to share with you the data about the use of CGM in pregnancies complicated with both types of diabetes, type 1 and type 2. So the beauty of technology in diabetes that we can see in the last few decades, it's mainly because of the development of real-time continuous glucose monitoring. And as we can see, the use of CGM is constantly growing, especially in these last 7 years. From 2011 to 2018, there was more than 30% of patients more on CGM, and we can see that it is the case in all age groups, especially in kids younger than 6 years, but also there is an increased CGM use in older age groups, more than 50, even more than 50 years. And this study is clearly give an answer why is this the case, because we can see here how CGM affect the level of HbA1c in those who are using this modern technology. And with the first black part of the column, we can see what is the average HbA1c in this group of examined patients, and it is quite high, more than 9%. And with use of pump only, there is a slight improvement, but not significant. And what really makes a difference is the use of continuous glucose monitoring, CGM, no matter whether the patients are using multiple day injection with CGM or pump. So the difference in metabolic control in those patients with diabetes, especially type 1, was made by use of CGM. So what about the diabetes? What is the prevalence of pre-gestational diabetes? It is increasing, and now in developing countries is about 0.6 up to 1.5%, and which is particular for type 2 diabetes in pregnancy. In pregnancies, this last couple of years, the prevalence increased even fivefold, from 0.2 to 1.06%, and actually, it is more frequent that pregnancies complicated with type 1 diabetes. Even this recent Australian studies shows that there is a 11.69 increase annually in pregnancies complicated with diabetes, which means that affect almost 1% of all births. So this is with both type of diabetes, and we do have until now many data about the use of CGM and its benefit in pregnancies complicated with type 1 diabetes, but we still cannot see that in pregnancies complicated with type 2 diabetes and gestational diabetes, and I will try to explain you why is this the case. So these are the newest targets for pregnancies complicated with diabetes, and what is most important, these are targets for those who are on CGM, and we can see that the target for time in range should be more than 70%, time below 3.5% should be less than 4%, time below 3.0 millimole per liter should be less than 1%, and time above range, above 7.8 millimole per liter, should be less than 25%. And you will agree that this is the targets that are quite difficult to achieve without use of CGM and constantly adjusting the insulin dose in pregnancies, especially with type 1 diabetes. And that it is very important, we can show from this recent trial that with the higher level of HbA1c, there are a lot of complications in pregnancies in both types, and type 1 and type 2, especially preterm delivery in those ladies, and also large for gestational infants or babies. And if we know that even 95% of pregnancies are in general population end up with live and healthy delivered kid, still maternal hyperglycemia is responsible for complicated 1 in each 2 pregnancies with type 1 diabetes and 1 in 3 pregnancies complicated with type 2 diabetes. So the ladies with diabetes really do have problems regarding the outcomes of their pregnancy. So now I will say a couple of words about type 1 diabetes pregnancies, and this is one of the landmark trials that shows what is the benefit of using CGM in pregnancy complicated with type 1 diabetes. This is a concept trial which was a multi-center, international and randomized control trial. It was included more than 300 women with type 1 diabetes, pregnant and those who planning to become pregnant, and they were randomized, assigned to capillary glucose monitoring with or without use of CGM. So the women were aged 18 to 40 years with minimum 1 year type 1 diabetes, and for those who were pregnant with type 1, the HbA1c should be about 6.5 up to 10, and for those women who were planning pregnancy, eligible for trial were those with HbA1c below between 7 and 10%. And these are the results of this trial, and here we can see with red line are the levels of HbA1c in women with type 1 diabetes in 3 categories: pregnant, planning pregnancy, and became pregnant. And we can observe a slight improvement in HbA1c, but enough improvement. And also these women reached the best HbA1c at the end of the pregnancy. And also the pregnant women which were CGM user, they spent more time in range, and also they had less hyperglycemic time, and also less and also comparable severe hypoglycemic events with those who were not CGM users. So these were clear evidence that CGM made a difference in the pregnancies of these women, or in their metabolic regulation, in those who were CGM users during the pregnancy. Also, there is observed a good results regarding their offspring. So there is a decreased proportion of large for gestational babies. And also there is on the part of this graph, you can see that with red line there is less neonatal intensive care admissions in those ladies who were on CGM in comparison with those who were just on capillary blood glucose measuring. The further analysis of this trial, concept trial, shows that it was analyzed CGM and hemoglobin A1C measurements in the first, second, and third trimester, And as we can see, there was a biggest proportion of women with higher time in range and also better HbA1c in the third trimester of the pregnancy. And with that, a lot of there was a big proportion of ladies that were able to reach nice and also ADA HbA1c targets at the 34th week of their pregnancy, and also ADA HbA1 targets were achievement was independently associated with a lower risk of preterm birth and large for gestational babies, and also neonatal hypoglycemic events, which shows that there is a clear benefit for women with type 1, pregnant women with type 1 diabetes of CGM measurement during their pregnancy and better titration of insulin doses. So the concept trial was a landmark study for CGM in type 1 pregnancy, and this was the trial which was the base in the 2019 consensus guidelines for time in range, as well as the American Diabetes Association standards of care for diabetes in pregnancy. And that's why now real-time CGM is a standard of care for pregnant women with type 1 diabetes, but we still need a further analysis to establish whether this CGM as a part of hybrid loop or closed loop system will bring us to the even better results regarding the pregnancies complicated with type 1 diabetes. So what about the type 2 diabetes? When we are speaking in general for type 2 diabetes, there is quite less evidence what is the effect of CGM in people with type 2 diabetes. This is one meta-analysis that analyzed 18 trials, and it shows that in patients with type 2 diabetes there are benefits in those who are using CGM in improving HbA1c regardless their treatment, age, and also baseline HbA1c, but we do not have any data about severe hypoglycemia or micro and microvascular complication in patients with type 2 and CGM. It is the same with pregnancy, so we have really few data regarding the type 2 diabetes pregnancy complicated and use of CGM, and to date there is no randomized clinical trial that specifically look into a benefit of CGM in pregnancies complicated with type 2 diabetes. And here you can see the summary of a couple of key studies, but they're, as you can see, all with mixed population of women with diabetes type 2, with diabetes in pregnancies. So in the first Murphy trial, this is just 35% of women with type 2. In the next studies, even less, 20. Then in the next 27, and even the final, just 15% of this mixed population was women with type 2 diabetes. And in this slide, you can see what is the sub-analysis, just what is the effect of CGM just in women with diabetes and type 2 diabetes and who were CGM users during pregnancy. And just the first trial, the Murphy trial, from 2008 was able to show that there is a benefit for these pregnant women with type 2 diabetes with higher time in range and with lower time above and below range, and also lower HbA1c, which reached significancy at the end or at the third trimester of the pregnancy. So the other studies regarding type 2 diabetes, they do not show any benefit of using CGM during pregnancy. So this is the Murphy trial. You can see that there is a better HbA1c and also less infant with macrosomia or large for gestational age babies. And it was showed for the both type 1 and type 2 patients with diabetes and pregnancy. So why why we are getting this data and why it is a kind of reluctance for use CGM in type 2 complicated pregnancies? I think so that this is very interesting trial that looks into feasibility and acceptability of intermittently scanned CGM for women with type 2 diabetes in pregnancy. It was a small study, but it was given a questionnaire to those ladies with type 2 diabetes and pregnancy who were exposed to CGM during their pregnancy. And here we can see very different results that we usually can see in ladies with type 1. So the mean sensor use was around 12 weeks, and 40% of these ladies beginning to use CGM in the first trimester. So the 60% started in the later pregnancy. So in the final 2 weeks of use, the mean sensor activity time was just 60%, with mean number of scans per day just 4.3, and the proportion of women with sensor activity more than 75 was just in 27% of these women. So this is quite different picture that we can see in ladies with type 1 diabetes, because in these women with type 1 diabetes, they started with use CGM in the beginning of pregnancy. In the first trimester, more of these women, and even more than 70% of them had sensor activity higher than 75%, which is at least necessary to get a really precise insight into the blood glucose, and of course to take some measures to improve this glucose variation during the pregnancy. So this was the questionnaire given to these ladies, and among other questions, what was the most of the women answer, the more than 50% of them, they were asked why there was a so small use of CGM, and their answer were that with CGM they were thinking about their diabetes more than actually they would want it to. So this is maybe because of the insulin regime, because the majority of type 2 diabetes ladies are on less complicated insulin regime, and maybe because we all still do not have a clear evidence that there is a benefit if the pregnant women with type 2 diabetes can control their diabetes with CGM during pregnancy. So, if I can conclude for type 2 diabetes, we still do not have data to support the use of CGM in all women with type 2 diabetes and diabetes, up to this moment, the recommendations are that decision or whether to use CGM in pregnancy complicated with type 2 diabetes and gestational diabetes must be individualized and must be based on our treatment plan or on their treatment or on patient's preference and needs. But I believe that it is not just my impression that CGM could really be a useful and well-received tool for improving the glycemic control in women with type 2 diabetes in pregnancy, and we really need a further randomized and controlled trial that will look specifically into use of CGM in pregnant women with type 2 diabetes in order to have more precise data whether this will be really beneficial and recommended to all pregnant patients with type 2 diabetes. And with this, I will thank you for your attention.
Thank you very much, Professor Tatjana. Any question?
Thank you very much, Tatjana, for a beautiful presentation. I've been doing the Joint Diabetes Antenatal Clinic for many, many years, where next to me, next room, is an obstetrician. The problem with the current CGMs, especially the Freestyle Libre, is they exaggerate hypos. So many ladies come to say, I have morning hypoglycemia as per the sensor, but I feel well. And when I double check, it is normal or even high. One of my patients was a doctor. She said, what do I trust? My SMBG says 100, my Libre says hypo. So in one case, I should reduce the basal insulin, and in the other case, I should increase the basal insulin. My advice was, continue with the CGM, but for the fasting, do SMBG. What are your thoughts?
Oh, I absolutely agree, because there is a big discrepancies between it. We know that it is a bit late, and still there is a difference between measuring of capillary and subcutaneous glucose, and of course this would be a real answer that they still need to perform capillary blood testing, not just to rely on CGM. And it is not just for the pregnant women. I think so for all of them, they need to control their CGM with capillary blood glucose measurements, because the Libre is one of the better CGM. It is even worse with some others. So we need to make this comparison between two methods still.
Thank you, Tatjana. Thank you very much indeed. So, not convincing evidence for benefit in type 2 diabetes. So what do you think we should do? I mean, there's a cost implication to this. I don't know whether the study you showed, they did a cost effectiveness analysis. I'm not sure whether they did. So what shall we do at this point? I mean, obviously, tight control is good for diabetes in pregnancy, but at the same time, CGM, the evidence is looking insufficient to make a recommendation. So one, what does it cost in your country? Two, are you going to roll this out widely into the community to say it's available, so go and use it?
Well, that's absolutely correct. It costs a lot. And I think so that especially in countries like mine, we cannot offer to all pregnant women with type 2 diabetes CGM. And even I think so that it will be the most beneficial in those who are on more complicated insulin regimes, on basal bolus, in order to have to make some improvement. We need to have more data and more money to offer this to all, because we know that type 1 there are still a very small amount of all pregnant women with type 2, and as we can see from the prevalence, it is especially rising in type 2 diabetes women. So of course that the money are issue, that's for sure, but and also this trial show that the women are reluctant if they are not really concerned a lot about their glucose regulation, their glucose variation, which is maybe not so much as those on those who are on less complicated regimes, on diet, on just basal insulin or something. But still my impression is that it is very useful method, and it can be beneficial for a lot of patients, even with type 2 diabetes. But we're still missing real data to confirm this. And that's why it's not a part of general recommendations for all pregnancies with type 2 diabetes.
Thank you very much, Professor Tatjana. And I think this is the end of our session. Thank you very much, Professor. Thank you.
Thank you.